Good afternoon, dear participants, and a very big welcome to our second talk show, Let's Talk Primary Healthcare. My name is Melita Jakab, and I am the head of the WHO European Center for Primary Healthcare. We are so excited that you chose to be with us this afternoon. We received more than 300 registrations to this webinar from over 60 countries. And to us, this indicates that there is continued eagerness to talk about the changing role of primary healthcare during this pandemic. And indeed, this is our goal with this talk show series. We would like to connect all of us enthusiastic about primary healthcare reform and policy into a regular dialogue. When we launched our talk show series in December, we looked back to the past year and we looked at the tremendous changes that have happened at primary healthcare level during the pandemic. We asked ourselves, are we seeing real transformation? Are we seeing acceleration of some important primary healthcare reform themes? Or are we seeing simply a short-term reaction to the changed context during the pandemic? Our conclusions were cautiously optimistic. For example, we have been seeing an increasing movement towards multidisciplinarity at primary healthcare level, with increasing integration of mental health specialists and social workers into primary healthcare teams. We are also seeing increasing delivery of services to people rather than people to services through increased use of phone-based consultations, digital platform, and mobile services to deliver care in people's homes. These are all policies and reform areas on which we have been working for a long time in many countries, and we now see them happening in real time. At the same time, we had a number of concerns. We had a number of concerns and preconditions that are required to make these changes truly transformative. On top of that list of concerns was the increasing workload at primary healthcare level. New tasks, new responsibilities have been added to those already providing a high burden for primary healthcare workers. How are we coping with this increased workload at primary healthcare level? Are we increasing resources in line with increased responsibilities and tasks? If not, are we setting priorities explicitly? Who is making decisions what services get delivered and to whom? On what basis do they make these decisions and with what process? And what is the impact of all these decisions on health outcomes, not only in the short-term pandemic context, but when we consider the medium and long-term? And this is the topic of today's conversation, priority setting of primary healthcare services during the pandemic. What impact on health outcomes? We're going to have a 1-hour panel conversation, and after that, we would like to hear from you, from your country experiences. We invite you to 2 breakout sessions to share with us and share with each other what has been your experience and your approach to priority setting during the pandemic. In the meantime, we invite you to say hello to us in the chat, share your thoughts, share your reactions to what you hear from our panelists, and ask your questions. My colleagues are monitoring the chat, and we're going to be taking your comments to the breakout sessions for discussions. With that background, let me now welcome our panel, and let me introduce our panel. First of all, I'd like to welcome Dr. Pia Vracko, Senior Advisor in the National Public Health Institute in Slovenia. Dr. Suvi Vainiomäki, who is a GP and Deputy Chief Physician in the Turku Welfare Division in Finland. Professor Dr. Mehmet Ungan, President of WONCA Europe. And Dr. Toni Dedeu, Senior Expert of our WHO European Center for Primary Healthcare. A warm welcome to our panelists, and thank you for taking the time to discuss with us this very important topic. And to begin, I would like to start our conversation by setting the scene and looking at how countries in our region have experienced this dramatic change and increase in workload at primary healthcare level. And let's hear the facility perspective first. Suvi, you're managing a primary healthcare facility and team in Finland. How dramatically did your workload increase? What have been some new tasks and functions to absorb? What happened to your previous commitments and previously prioritized functions? How have you coped?
Thank you, Melita, and greetings from Finland. Yes, in last spring, when COVID started spreading, there was a lot of new tasks for primary healthcare, and sometimes I even thought that everything is our responsibility. The main things were testing of the mild COVID cases, and then also infectious diseases. We had to create an own clinic for infectious people so that there would be no spreading amongst chronic diseases patients and such. Then we have to do the tracing of COVID, so that's a new job, and also now the vaccinations. So everything seems to be our responsibility. Of course, the seriously ill are going to the secondary care. And that was really a hard job for us. We in springtime, we had a lot of resources from the preventive care. We had nurses from there, and also we have we closed all our chronic clinics in the springtime. But now, after summer, we have had everything open. We are trying to go on as we were with the chronic diseases and such. But the problem is that we have so much input from so much contacts from patients and so much contacts from vaccinations and sampling of COVID. So we really have lost our nurse resources to the COVID. So that's making it really difficult for GPs to do their work alone, kind of.
Yes, Suvi, thank you very much. So you're very much confirming to us the dramatically increased workload and setting priorities. Some services discontinued, some health workforce actually allocated to other tasks. Let's contrast your experience with that of Slovenia. Pia, what has been your experience in Slovenia? And let me just add that Slovenia really stands out among many countries with the very strong alignment of public health and primary healthcare services. Has this symbiosis helped you to make good decisions and cope with the workload?
Thank you, Melita, and hello, good morning and good afternoon from Slovenia. Well, in Slovenia, public health system and primary healthcare system are two separate solid systems. They have been operating hand in hand with great emphasis on ensuring public health approaches in primary care, offering health promotion and disease prevention services at individual level, and engaging with communities to outreach to vulnerable individuals and populations, and thus addressing health equity. Community health centers, which are the basic primary healthcare facilities and offer health services to address a broad array of health needs at one location, close to where people live, employ professionals of multiple medical and healthcare disciplines. And during the COVID-19 epidemic, these multidisciplinary teams could absorb relatively well the increased workload of the epidemic by quickly reorganizing to provide the new services related to COVID-19 while still continuing the majority of usual essential health services. Being the entry point to the health system, primary healthcare in Slovenia continues to provide this function also during the epidemic, providing testing capacities, ensuring separate care pathways for COVID and non-COVID patients, vaccination, providing medical care for mildly and moderately ill COVID patients, along with triage, counseling, and all other usual services and tasks. While National Institute of Public Health with its regional units, and of course also national unit, they provide field epidemiology, population-level health promotion and disease prevention, and health intelligence operations. But it is the primary health care that actually plays the vital role of the national pandemic response at individual patient level. It ensures that that only severe COVID patients are referred to hospitals, which protects hospital capacities to treat the more severe and critically ill patients. So to answer the question, yes, community health centers at primary healthcare with multiple primary care clinics and multidisciplinary teams could ensure flexibility to quickly adapt to new service delivery modes, while also ensuring optimal use of limited resources.
Thank you very much, Pia. Professor Ungan, let's come to you now. And I would like you to wear your hat as president of WONCA Europe. In your network, you're regularly conversing with family physicians, general practitioners, nurses. What are you hearing from your colleagues in this regard in terms of the workload over the past year? You're muted. Just 1 second. You're muted.
Sorry for that. I always do in the Zooms and the webinars. I'm sorry for that. Thank you, Melita. That is a very important question, actually, because we have been waiting for our problems to be discussed also, but also in the primary care perspective. So we know, and also it's in our website, that we lost considerable number of general practitioners, family doctors, primary care professionals in the pandemic, during this pandemic. Why? This is a question really that we should be answering also ourselves. Being unprepared, less supported, infrastructure, lack of teamwork, and misused systems. Why? Why many colleagues had burnout and still have the burnout? And is that because loss of person-centered care and its relation with the high burnout among the primary care doctors and primary care workers, professionals? So I will just try to focus only for the GPs. And maybe this is very important for us to know and to act according to the 6 core competencies of the GP for general practitioners. Primary care management, patient-centered care, problem-solving skills, comprehensive approach, population-based and holistic approach. We cannot say that all of them could be filled in. We are having worries for ourselves and for our population in the primary care. First of all, the primary care management was good in some countries, like, for example, Slovenia. But in some others, majority, the GPs made adjustments they have applied to cope with the governmental guidelines. There are guidelines in primary care by the governments. So it changed the working style of the GPs. The first contact turned to telephone mostly, Online appointments are closed. Sometimes patients waited out of practice to take care of the measures for the infectious disease. So psychology consultations got harder. Those are all primary care management side what we have faced with. According to our researchers in the primary care, the patient-centered care was also, not perfectly okay in most of the places. The loss of nonverbal communication, limited ability of some patients to articulate their needs, intercultural communication. So those are, I think, those are the worries. There are a lot of, we can go. But for the third item, problem-solving skills of the GPs, as there is a large focus on COVID-19, we thought that we would miss other diagnoses more frequently, which is also accumulating the problems for the future, which is an important one. So the comprehensive approach, the most important item is about the chronic problems. We could deal with them less effectively. The priority for COVID-19 pathology is one reason, and the fact that the patients present less often for their follow-ups is another one. And we can just say that consultations and home visits are reduced to minimum, although we had difficulty in deciding which patient contacts can be postponed safely. Recurrent drug prescriptions were a problem at that moment, and we saw that it can be sent straight to the pharmacist, and there were some kind of, regulations in. And I will be on the fifth one. This is the community orientation, which is really very important. I think some of the GPs in some parts frustrated with the sickness certificates issues in practice. Although it doesn't seem like a major primary healthcare problem, the GPs describe their frustration as feeling like an ink pad. This is what I like, much of their time went to writing sick leave certificates, digital prescriptions, writing mails, and so on. This is official thing. And what about the holistic approach? Most of them pleased with the way the government is handling the epidemic, to be honest, according to the research. However, many worry about the psychosocial consequences of the outbreak, and more specifically about the lockdown measures to control it. So loneliness, depression, intra-family violence are seen more frequently, according to the data. Problems are also detected in persons who previously had good mental health. Some people are unable to cope with the new situation, and children with vulnerable families, loss of income, or jobs with influence health and welfare in the long term. Those are all problems we should be losing. We shouldn't be losing the holistic approach. Last words, I think I can tell you 50% of the population stopped going to general practice, primary care, and which is very important. I will not go in detail in that. For future health conditions may worsen following this acute phase and spikes, exacerbations, let's say, of COVID-19 pandemic due to disruption of care, underdiagnosing of potentially urgent health problems, prolonged isolation, and increased risk factors for health. I think strong primary health care is best placed to address the surge in care needs. How we will do that? I think by reorganizing the delivery of primary health care, rearranging tasks and responsibilities in primary health care will lessen the burden of repeat prescriptions and such kind of things. About discussing the digital tools and systems, add-on payments may be discussed. So I will stop here. There are a lot of problems.
Thank you. Indeed, I think that's a very powerful list of concerns that are in part the outcome of a massively increased workload that we may have challenge dealing with without prioritization. And that brings me to you, Toni, to reflect a little bit on this word priority setting. Why do we really need to set priorities? Why is it important? And what happens if we do not set priorities? Over to you.
Thank you, Melita. Thank you all for attending this talk show. Good morning, good afternoon, good evening. As you said, Melita, primary healthcare has a comprehensive and wide-ranging basket of services and competences, ranging from prevention to health promotion and population health. As other panelists have mentioned, priority setting should ensure continuity of essential health services and coordination with other care levels. And so there are questions we need to think about. What are those essential services and what resources do we have available in such a crisis? Priority setting ought to be contextualized in each jurisdiction. For example, in territories, in regions, in municipalities, in line with the population needs and workload. Context and available resources matter in priority setting. With an eye to the future, priority setting is important to reduce the accumulating backlogs due to the primary focus on COVID-19 patients, but also to start addressing the needs of those suffering from long-term sequelae of COVID, including mental health conditions, as Professor Ungan just said. And priority setting should include proactive and fast-tracking strategies from the word go, for leaving no one behind. And what happens if we do not set priorities? And in healthcare, we should work towards eradicating the postcode lottery. The goals of health systems are to maximize equity, fairness, access, and quality of care. And ethical issues for policymakers should also be into this equation. So the impact of random and reactive management leads to health inequalities and will impact as well on health outcomes of individuals and the population at large, but also can put sustainability of health systems at risk. Evidence will demonstrate if this hypothesis is confirmed. There is lots of work, lots of research to do still, so I encourage researchers in primary care to start working on that. And priority setting at primary care level for non-COVID patients is a fundamental instrument to respond to people's needs. And who should and who is already setting these priorities? Melita?
Toni, thank you. You set me up so well for the second round of our discussion, where we would like to dig in deeply into priority setting mechanisms and demand management tools that work. But we would like to start to hear from our audience. We have designed a poll with 2 questions to hear from you a little bit how priority setting during the pandemic has worked in your country. Indira, could you please put on the screen the polling questions? So we would like you to first answer, in your country, did primary healthcare facilities receive clear guidance on what services to prioritize and deprioritize during the pandemic? I give you a few seconds to read the answers and vote. And once you have voted on the first question, you can go to the second question. If there was a clear priority setting process, we're interested to know who was involved in the priority setting process during the pandemic. The votes are coming in very nicely. Okay, I suggest, Indira, could you please pull up the result of the voting? All right, very interesting. About 30% of you say that health facilities received guidance on priority setting, and it was clear and helpful. But double of that, 70% of you say that health facilities received guidance, but it was not clear enough and facility managers needed to make decisions. And there was a small percentage of countries where health facilities received no guidance on what to prioritize. Let's look at the second question. Who was driving the process? In most countries, the process was a government-driven process, mostly driven by Ministry of Health. In some countries, there was also limited stakeholder involvement. And in a smaller number of countries, it was a truly multi-stakeholder process. And of course, it's this latter one we really look forward to hearing about. It's clear that we see wide variation in priority setting strategies. So let me now invite our panel to reflect on these results and share their experiences from their countries. Professor Ungan, do the results of this poll surprise you? And more importantly, now we're in the solutions section of our discussion, what can we do to better support the frontline decision makers, the primary healthcare facilities?
Yeah, that is, thank you, Melita. Thank you for the participants for this survey. Actually, the numbers are quite, I think it is not a surprise when I thought and when I saw the primary care in Europe. But also on the other hand, I would very much expect the first question to be answered a high rate, which would be the ideal one, actually, according to me. I think many countries, unfortunately, what we observed is that in every country there were how do you call it? I don't know, but consultants, let's say around the Ministry of Health or around the Health Directory for a consultation group like we were calling, in some of them are pandemic committee or something, who were including the stakeholders in this country, including, of course, secondary, tertiary care, but also primary care. But the inclusion of the primary care organizations, the more they were inclusive, the better results, what we have observed. So that was actually in line with these poll questions. So less countries included the primary care the responsible people and also the stakeholders in the primary care into the decisions and guidelines in this pandemic, which ended with question marks and with this poll. Strong primary health care may be better organized in multidisciplinary teams, according to my belief. And with innovative roles for the health professionals, integrated with the community health services, as in Slovenia, equipped with the digital technology and working with well-designed incentives. This is important. But don't forget that the health systems during the COVID-19 pandemic focused on scaling up of hospital capacities, which was wrong at the beginning. However, the pandemic is deeply affecting the health of many people in our populations and in primary care. What happens to who are not infected by the virus? Nobody thought about it, and only the hospital services were, prominent at the beginning. It is late that they understood. Most of them understood that primary care should be really focused. People living with chronic conditions are not only vulnerable to complications and death from COVID-19, but they are also suffering from disruptions to their regular care routines, which was important. I think strengthening the front line with primary health care helps with the health system adapts during the COVID-19. A few minutes ago, I thought that I think we need to reorganize the delivery of primary health care for sure, and rearrange the tasks and distribute it and draw the, the borders of the tasks very well. But we get to use the digital tools and systems, and add-on payments should be discussed, I think. This is what I will say right now, if you don't want me to say anything else.
No, that's excellent, really, to get us started. Let's now see how our two countries, Slovenia and Finland, have set priorities. Pia, let's come to you first. What has been the process in Slovenia? Could you outline for us? And I'm sure that the details will be very useful for all our participants and listeners.
Yeah, thank you. So aligning the operations of all primary healthcare providers across the country was indeed a challenge, because there are so many across the countries, right? And especially because the community health centers are owned by municipalities, and there is actually no national level primary healthcare governance and leadership line. However, due to the emergency situation, the Ministry of Health took strong leadership on issues related to COVID response, on testing strategies, isolation, quarantine, guidelines on obligatory establishment of separate patient pathways, and so on. The Minister of Health nominated the Scientific Advisory Board on COVID response, just the one as Professor Ungan mentioned. And in Slovenia, it is constituted by specialists of infectious diseases, pulmonary diseases, intensive care, microbiologists, but also primary care providers and public health and epidemiologists, and directors of public health institute, of hospitals, and of community health centers. So this board really brings together the key stakeholders in the country who together look for the most appropriate solutions to the COVID pandemic and management. I must say that very valuable role is also played by professional associations and providers organizations who serve as a kind of amplifiers, ensuring the two-way communication between the providers and the Ministry of Health. This is related to COVID, but I must say that prioritization and organization of non-COVID health services continues to be responsibility of individual primary care practices and community health centers and their managers. Additional phone lines were established for counseling and triage purposes, and we are observing a massive increase in remote counseling and other e-health services like e-prescription and e-referral. And of course, face-to-face appointments are not as frequent as they used to be before the epidemics. But this is possible because the patients are registered or empaneled with their chosen doctor, either GP or pediatrician for children, who know their patients well and can thus provide proper care and ensure continuity of care without seeing the patient. Another essential element that ensures uninterrupted access to healthcare and effectively addresses health equity issues is full coverage of all multidisciplinary primary healthcare services by mandatory health insurance, including reimbursement of drugs prescribed by primary healthcare providers for the common health conditions. So all these factors make possible also the e-referrals and e-prescriptions to function really well. Majority of other primary healthcare programs like primary healthcare gynecology, dentistry, mental health services, cancer screening programs, community nursing, physiotherapy, and other therapeutic services, as well as diagnostic services and emergency care, they continue to operate under strict protective hygienic measures, of course. However, I must say that NCD's screening program, which is delivered by specially trained nurses as members of family medicine teams, and the activities of health promotion centers, which provide workshops for support for healthy lifestyles, they had to be discontinued mostly due to because their staff was allocated to provide COVID-related services. And this discontinuation of NCD screening and health promotion centers was implied by governmental decree. But now with getting back to a little bit lower levels of COVID-19, we are re-establishing these services too.
Yes, thank you, Pia. It sounds like Slovenia has really had a thoughtful approach to setting priorities explicitly. And it's very interesting that even with such a thoughtful process, a large share of these decisions are left to the primary healthcare facilities, centers, and managers. Suvi, that is really perfect time to bring you in. You have been in that role and you have had to make tough decisions. How has this worked in Finland? Who has set priorities to what extent? And how you as a facility manager complemented those decisions and made these difficult choices?
Thank you, Melita. Yes, I was just listening to Pia, and there are very much similarities with the Finnish system. Also, we are government led. We have like Ministry of Social Welfare and Health and the National Institute of Health, who were kind of the main policy makers. We also have our local state administrative agencies who also set up policies, and many pandemic groups have been established this year, and they are working in national and local regional levels. But I still think that quite much of the prioritization still goes on in a GP's head when she or he is thinking, should I meet this person personally? Should I make the status and feel her stomach and listen to the heart, or should I just remotely put her on a referral to the laboratory and hope that everything is okay? So this is kind of the prioritization which is going on GP's head all the time, and we don't know what we are missing because we don't meet the persons closely. The things that we try to do to manage with the huge overload of jobs, for examples, that our nurses are doing all this stuff, we tried to automatize COVID sampling so that there would be no need of healthcare personnel there, and that is quite well happening at least at my region. And that way we were trying to relieve the pressure so that we could use the nurses on their on the care of the chronic care patients. And we were just starting to think that now we can do it, but then we started vaccinations. So now we are on the same problem again. So it's really hard to prioritize when everything goes to the COVID work. We also are trying to have multidisciplinary teams so that nurses and GPs are working together, and trying to have them working with chronic care patients and the most vulnerable patients. But because of the workload of the nurses, we don't really manage that so well. So there are problems in the prioritization, yes.
Thank you. And I think that's a very important new perspective that you're bringing in. No matter how good is the priority setting process at national and regional level, we also have to think of the efficiency of how we deliver services and where we can take advantage of these new digital and remote consultations to free up resources that we have at hand. So thank you for that. I think that has been very, very helpful. Now, Toni, I'm going to ask you to wear a policymaker's hat and to make some useful recommendations for our audience how to set priorities well and explicitly. And let me just give a little bit of a narrative to my question. We often find in WHO that when countries think about priority setting, they would really like to receive a list of services, something very definitive and very explicit. And of course, such lists exist. They have been based on cost-effectiveness analysis. And this evidence is very important for priority setting. But it is not sufficient, because priority setting is not just about technical decisions and technical analysis. It also has to map to public values, the trade-offs between efficiency and cost-effectiveness and equity, and how much we want to incorporate the perspective of communities and vulnerable groups. So it becomes a very complex exercise, which works well only if there is a multi-stakeholder process around it. And I think it's very important to consider, when I asked Pia, for example, how has Slovenia set priorities, she did not really talk about the list of services, of inclusions and exclusions, but she really focused on the process that has been established to make sure that those decisions reflect various stakeholder positions and various perspectives. So with that, Toni, if I may come to you now, what advice would you give to policymakers to do this well? And while you're talking, my colleague Jose will copy and paste some resources into the chat that you may want to consult as you go forward.
Thank you, Melita. From a policy hat perspective, I think I'm going to go for the practical side of my intervention, and I would like to share with you a very practical and pragmatic example of a COVID-19 workload prioritization guidelines developed by the Royal College of GPs and the British Medical Association GPs Committee for clinicians working in general practice in the UK. as an important highlight of this guidance that could be translated to other countries is that it complements and does not substitute the local and national guidance from the NHS and the government bodies. Most probably, this is common to many other countries. The guidance and recommendations ought to be aligned, and this is something that the three panelists have already said in this slot. So the key learnings from this guidance is that the COVID situation is changing rapidly, and that any guidance should evolve according to the pace of the pandemic. So the initial question is whether practices have been able to restore some or all routine services, and pressures on essential and routine services are not uniformly felt across the different regions and nations, and either in the UK, either in different countries. So going back to the guidance has three key messages that can be used in other countries. One is flexible response. There is no single one-size-fits-all blueprint for how practices should operate or what measures should be taken to manage workload. A second key message is to let people know general practice is open. In other words, primary health care does not shut. The guidance emphasizes patients will be seen face-to-face where it is clinically appropriate, and patients with potential serious symptoms should be encouraged to contact their surgery to enable an assessment. And finally, it's about local decision-making. For example, in the UK, clinical commission groups or health boards across the 4 nations of the UK will need to work in partnership with local GPs, other health and social care partners, and patients. Of interest of the British guidance is the development of a red, amber, and green ratings guide, which is used to inform these discussions, and then once agreed, would be useful as guide for clinicians and patients as to what level of service can be reasonably expected. I think you can find this red, amber, and green ratings guide in the link now. So several countries are using instruments developed before the pandemic, and this is a key message. Let's go back and what have you got in place and how can you use them? Examples of population stratification according to health needs and complexity for chronic patients have resulted in fundamental tools for reaching especially the most vulnerable and frail. Many regions in Italy, Spain, and the UK, to mention a few, are using risk stratification tools. There are a few examples in which risk stratifications include socioeconomic and demographic information too. And primary care networks, a multidisciplinary team approach, are seen in Finland, as we've seen, and in Slovenia, and community-oriented primary care strategies in some other countries. Not to mention triage systems, telecommunications, self-management, digital solutions, etc., etc. So this is my input from a broad view, but going narrowly to a very concrete example.
Indeed, I am very grateful for that very concrete example. Thank you very much for that. I also very much like the point that we have talked about priority setting a lot prior to the pandemic. In all countries have developed tools and processes. And what we need to do is reapply and reutilize those mechanisms that we used prior to the pandemic. What really prevents us or has prevented us from doing it is the very strong time pressure and resource constraint at all levels of the system. But now that we're a year into the pandemic, I think it is worthwhile taking a time and considering this dramatically increased workload at primary healthcare level, its potentially negative impact on the delivery of services, on the health workforce, and take a breath and think about how can we set priorities better and how can we increase and align resources in line with those priorities. We have come to the final round of our talk show, and in this final round, I would really like us to look ahead, and I would like us to take a medium and long-term perspective. During the pandemic, we have been acting very much in a reactionary perspective. We responded to have dramatically changed situation. But how do we come out of this? Because when we do that, we solve the problem at hand, but inadvertently, we may create other problems, or we may not consider a more holistic, long-term population health and well-being perspective. For example, Pia mentioned that health promotion, health education services have been shut down. Suvi mentioned that nurses have been moved from health promotion, chronic disease management work to pandemic response. What impact does that give us in the long run? In the long run, could it be that it creates a big negative impact on health outcomes, while in the short run, that is the rational decision? So how do we anticipate better the future health needs? And how do we plan service delivery in this anticipatory manner? And Toni, let me bring you in first on this. Could you please talk more about how do we understand anticipatory planning of health needs and anticipatory planning of service delivery?
Thank you, Melita. Anticipatory service delivery planning, in fact, is the translation of anticipatory care planning, but at the population health and the whole system level. But I'll start saying, what is anticipatory care planning? Its origins are in palliative care and has expanded to all care levels and health conditions, where health and care practitioners work with patients and their carers to ensure that the right thing is done at the right time by the right person. It's about working with the patient and people close to the patient to help the patient understand what services are available, how to use the health system well, and their condition as well. So anticipatory care planning helps patients make informed choices about how and where the patient wants to be treated and supported in the future. So anticipatory service delivery planning takes some anticipatory care principles. It translates them at the population health level. It helps decision makers and healthcare providers anticipate health needs, especially for population groups in defined territory areas, identifying needs, clustering population, and anticipating the type of health services needed. And as I said, to give response to population health needs, it flags vulnerable and frail people populations as well. One of the key elements in this scenario is the information data collected at primary care and public health care. And this is going back to Pia's concept about this integration between the two systems. The best picture of the people in a community comes from primary and public health care. This information, in conjunction with the collected from other sources, allows us to predict, anticipate service delivery planning, and provide the right service at the right time for the right people. So this is not only about data, it's a dialogue between different sectors, actors, and the community to set up priorities. The most relevant components, in addition to information, is the consensus building and context focus. In this crisis, we have seen that it's essential to develop proactive strategies and set up priorities to anticipate health needs during and post-pandemic recovery. At population health level, this cannot be done without primary health care or public health, either in a coordinated manner or with some level of integration. And I see this as the beginning of a successful marriage.
Thank you, Toni. That was really setting the scene very well. And it's a very interesting question on which I look forward to bringing in the rest of the panel. But before we do that, let's ask our audience what they think. Indira, could you please launch our next poll? And we would like to hear from you. In your country, which 3 strategies would help to move from reactive to anticipatory service delivery planning? And the answer choices are a little bit complicated, so I'm going to give you a little bit of time to read them carefully. I will also say that you can choose 1, 2, or 3 of the most relevant strategies. All right, Indira, could we have the result? Very interesting. So let's see. The most voted strategy was to have more detailed information on population health, risk and vulnerability at community level. That's very important. In fact, 73% of you voted for that strategy. In second place is further integration of health and social needs into primary healthcare, with 61% voting for this. And then there is a tie for the third place, very much. But I would say expansion of facility autonomy to form multidisciplinary teams tailored to local health need, very, very closely with catching up delivery of neglected services of public health impact. Thank you very much, Indira. You can remove the result. Let me now come to this with the panel. And Suvi, let me start with you. What are your reflections on the poll? And could you narrate the strategies that you see most promising to practice anticipatory care planning at your facility?
Thank you, Melita. Yes, the poll is like, it seemed like I would have been answering it. It was quite hard to choose between the all the multiple questions. I was thinking this question really close to patient doctor or operative level, and also in an administrative level. What we need here in Finland, at least, is more skills in motivation and coaching skills of the doctors and nurses, so that we can get the patients themselves into the making the care also, because you don't lose weight in your doctor's appointment. It's the 355 days that you lose weight. So it's the motivational skills, they should be really made better, and we need more education about them. Also, we should have more ways to identify the most vulnerable patients, those that come to our door every week, that have some acute questions, but the problem is still really deep, some other mental health issue or something. So we need to identify those patients more closely. On an administrative level, I would I dream of such computerized things that I could get more precise knowledge of how our treatments are going. They should be really easy to use, and we need more data of our patients. So I think they are one of the things that I would dream about. Thank you.
Thank you very much, Suvi. That's really great. How about Slovenia? Pia, what's your reflection on this poll? And what tools have you already engaged for anticipatory health needs and care and service delivery planning? And if you were to dream, like really dream, what would be your priorities for the post-pandemic recovery of primary healthcare in Slovenia?
Well, thank you. This is really an important question and discussion, and health needs of population really need to navigate the prioritization and anticipatory planning of primary healthcare services. So actually in Slovenia, we already have a very, very strong population level health information system that is used to design the services at primary healthcare. But let me also mention some system challenges that need to be addressed if we want to further increase the performance of primary healthcare services in post-pandemic recovery. So there is a very strong need in Slovenia to strengthen the system capacities to monitor primary healthcare performance and to establish effective accountability mechanisms to ensure the resource allocations and purchasing mechanisms support the achievement of national priorities identified in the National Health Plan or other sector-specific strategies. And these institutional capacities include like establishment of a unit or department or agency for continuous quality development at primary healthcare that would include all services and programs delivered at primary healthcare, not only family medicine or primary pediatrics, not only medical services, but the whole multidisciplinary programs. We would also need to establish an independent professional or technical institution devoted to continuous development of primary healthcare system and services. And of course, in addition to population level health information system, which is completely provided by Public Health, National Institute of Public Health. So this is another area of very strong collaboration between primary healthcare and public health services. So at the system level, it would be also great if we could use these health information system tools to identify which services are provided more at primary healthcare facilities, which are provided less. Because now it usually happens that what we mostly hear from those providers who are most engaged, and we don't hear from those who don't speak up or never show up. But we actually want to know what's happening with those from we don't hear from. And that's why we would really need this health information system that would allow us to see into all primary healthcare providers' performance. And very important, just to conclude, I expect that with the post-pandemic recovery, especially the outreach services will be so important, because we will need to identify the vulnerable populations, the vulnerable individuals who did not seek medical care during the COVID. And I think this will be the priority for primary healthcare in the whole region. Thank you.
Indeed, thank you very much for that. Professor Ungan, I'm coming to you. As you saw in the poll, participants evaluated very highly the strategy to further integrate mental health and social services with primary healthcare. What new skills and competencies we need to develop in primary healthcare so that they can effectively address social vulnerabilities and health inequality?
Yeah, this is a very live question now, and I think we have to discuss as the all stakeholders, including the primary care organizations, and also I think the GP family doctors should be also discussing in national level, because I think although we have the WHO guidelines which should be followed, as you know, as Toni said, a one-size-fits-all model will not be totally appropriate, although the general rules are okay. Each country, each city, each primary care region must continually assess which members of society are really in need and to fairly support those at highest risks, actually. So for those things, I think we can just go for the vulnerable groups with the public health specialists with the epidemiologic approach. We have to find them. But what skills are important now? I think what we have learned is we cannot restrict what we really need, because if you remember, the general practitioner need or family doctor need existed because of such kind of worries. This is something like when you see it, a physician who will do everything in a very skillful manner and providing the service to the families and the public actually. So it is not easy to leave only to define the skills are this and this is the only one. It will be, as Pia said, I think we should not fix on one thing, but we should always live with that and develop it. So I would say, I will not say we may, but say that we have to learn new skills. such as digital patient record systems should be widely, learned and used. Working, connecting to the health systems, primary healthcare, and family medicine integration shall be really well defined on education, research, quality, and as an academic discipline. General practice family medicine specialty shall be widely accepted by each country, each and every country. Special trained task force health professions for primary care services is very important. Not only the GPs, not only the family doctors. Skills on using a common coding health information systems in active life of the population should be integrated with the patient organizations also. This is because a live system. And gathering data to plan, to act, and to monitor your own region is important. And those require skills. Making reliable assessment while the patient is not in the same room is another problem, for example, that we should be developing our skills. And on the other side of the line, there is a patient and you are taking care of that patient. We have to learn it in a proper way, actually. And GP training of the future with a greater focus on the telemedicine skills, I can say. Video consultations, motivation skills, teamwork skills, new housing and operational rules, making decisions virtually, delivering education via video conferencing. Those are all the skills what we really have to think.
Yeah, that is not a small agenda to integrate into our health worker training. And we have come to the end of our panel discussion. Toni, I'm going to give you a very challenging task. I would like to wrap up our conversation to talk about how you see the future model of primary healthcare evolve to take into account all this discussion in 30 seconds. What would be your top 3-4 headlines? And I promise we will develop future talk shows around those to dig into the details.
Thank you, Melita. I think what we have to sum up and what we've heard in this talk show about the strengths of primary healthcare, and those are many. I would like to focus the multidisciplinary and team-based approach, primary healthcare as an integrator of care processes, a strong community base, and a wide network of services at primary care levels, which allows continuity and quality of care. These would be the key principles, and we should keep working on that. But nothing has a bigger impact on health outcomes than a human face-to-face side of primary health care. So thank you, Melita.
Thank you very much. And with that, I would like to thank our panel for their wonderful contributions. Thank you very much indeed for sharing your experiences and thoughts. And now I'm turning to our participants. Those of you who joined us only for the plenary discussion or the panel discussion, thank you very much for taking this hour with us. We would really appreciate if you could fill out the survey when you leave this session. And those of you who stay for our breakout room discussions, please join us. We're going to have 2 breakout rooms now to hear from you, from your country. How have you set priorities? In the first breakout room, we will have a conversation in Russian language, moderated by my colleague, Dr. Arnoldas Jurgutis. In the second session, we're going to have a conversation in English language, moderated by our panelist, Dr. Toni Dedeu. Our panelists will also be joining the conversations, so you will have further chance to interact with them on a face-to-face manner and ask them questions and further resources. And we look forward to hearing from you. I thank you for your participation and attendance, and I see you next time.